G'day, Spartan here from Lung and Sleep. In this video I'm going to demonstrate an interesting case of a patient with a lung cancer. This is a man who presented with haemoptysis, and on clinical examination he had some crackles in the bottom of the left lung. Now I'm going to show you the chest x-ray, the CT scans, the bronchoscopy findings and how this was biopsied, and then what the subsequent treatment was. Hope you enjoy this and find it interesting and you learn something from it. This is a plain chest x-ray which was performed, which was the appropriate initial investigation. And here you can see that there's an abnormality around the left hilum. Here it is here. It looks as if there's a soft tissue mass here, but it certainly looks fuller than the right hilum. So this certainly requires a CT to further define what the abnormality is at the left hilum. So here's the CT scan. Now if we just have a look at the lung apices, and we'll adjust the windowing so we can see that there's a bit of emphysema through the lungs. As we scroll down, there's a little bit of emphysema suggesting underlying smoking-related lung disease. As we scroll down, wow, we can see that there's a big mass right here. There's a big mass here that is probably originating from the lung, given that it's got an irregular border here with the lung, but it's extending right into the mediastinum. Here's the central trachea. Let's just scan down, keeping an eye on the central airways, because remember that this person presented with haemoptysis. So we want to see, although we've already identified that there's a big mass, has this mass contributed to the presentation of coughing up blood? As we scroll down, we can see here is the left main bronchus, and here's the division into the upper lobe, and it's irregular. This looks like tumour invading into the distal left main bronchus. There's some abnormality here as well. And there we go into the lower lobe, surrounded by tumour. If we just come back a little bit, we can see that there might be the airway going into the upper lobe is tiny. It's almost completely obstructed. The upper lobe is aerated because it has not collapsed, so there must be some air getting through, but not much. It won't be long until that obstructs. We can also see here that this is the main pulmonary artery branching into the left pulmonary artery, and that's indented by this tumour. The mediastinal windows gives us some more information. Once again, we can see a big, large mass here. There's also associated right paratracheal lymphadenopathy. And we can see the compromise of the pulmonary artery here, an invasion of the pulmonary artery. So this is a T4 tumour based on invasion of the mediastinum. It's at least a N3 because of contralateral mediastinal nodal metastasis, but that needs to be confirmed pathologically. But I think the first investigation in this situation is a normal bronchoscopy to investigate the airways, because the patient presented with haemoptysis, and that should probably give us a tissue diagnosis as well. So let's go and do the procedure. So here's the bronchoscopy. The bronchoscope is now in the main trachea. We can see the main carina with the right main bronchus there with some normal secretions, no lesion there. Now we'll go to the left main bronchus where we know the tumour is. You can see a bit of abnormality at the left main bronchus there, but in the distance we can see clear evidence of tumour. There's endobronchial tumour there. It looks quite vascular and quite likely to have caused some bleeding and haemoptysis. We can see aeration to the lower lobe, but we can't see into the upper lobe at all. So we can perform an endobronchial biopsy of this. We'll get the biopsy forceps into position, just test them, and now we can go back to the tumour. Now the first biopsy is the most important because there's always a little bit of bleeding, so the first biopsy is the easiest, so it's important to get a good piece of that tumour, and then we can go back and take further biopsies. And there we go, we've got a good piece. So the biopsy result showed squamous cell carcinoma, and this is unfortunately a common smoking-related lung cancer that often affects the central airways. A PET scan was performed, and unfortunately for this person showed that there was evidence of some metastatic disease, and so a curative approach was not possible. So he was treated initially with palliative radiation to the main tumour and the endobronchial component, because this is very good treatment to reduce coughing of blood. He was also in good performance status, so was treated with systemic chemotherapy. So I hope you found this case interesting and were able to learn something from it. I'll do more videos like this, so please subscribe to my channel and you'll be notified of further videos of different interesting things related to lung disease and sleep disorders. Okay, bye for now.